to the and to the people who actually made it possible.
She organizes
All
lot
the
of
colleagues.
webinars. I have actually attended a lot, but I am now waiting that she organizes a physical one because she's doing it regularly and she is very active in UTI. So that project also webinar she is regularly doing a lot.
But this way, a lot of people.
Now it is right time that you organize something physical.
Right.
Now
This is
a
a.
lot of people are together. Big platform now.
This is how a lot of people do join. Who may or may not be able to. There's so many conferences happening, so many webinars and seminars and symposia happening.
Yes.
So and they're good quality things which are happening. So it's very difficult for people to choose. This way, people want to know something which is how to proceed with the challenges on ground, and so I think that is where we connect very well.
Yeah, and One Health is one of the priority of Government of India and ICMR also. So that way also it is very good. This topic is
right.
quite like suitable.
So Dr. Zaima is the current head of microbiology and immunology. Is that right?
Yes, Dr. Raman. How are you?
All God's grace. All God's grace.
When we started this, I was the assistant, so now I have become the
right. That's how I remember that.
Yeah. It's always a pleasure to be here with you. And yes, I agree with you. Dr. Mihir has been working very hard on this, putting all these groups from around the world, and organizing this symposium is a blessing actually to all of us to hear your thoughts from your experience also and your research. So it's an honor for all of us. Thank you very much.
Hi, welcome, Dr. Petris.
Hello, how are you? I'm sorry, I'm just a little late. Connection, Zoom US, Zoom Europe, Zoom Switzerland, and Zoom everywhere. So now I'm ready. If you wish, I give this lecture.
Yes.
So, are we on board now, or shall we start?
Yes, sir. Yes, a slight change in the program. Dr. Sanjeev Singh will not be able to join. His wife unfortunately fell ill. So I was just waiting for him. So since he's just phoned up, said he won't be able to come, we're going to begin now. Yeah.
Hi, welcome, Dr. Abdul.
Hi, good evening,
my friend.
Hi, Maher.
Hi, lovely having you.
Salam, Zaima, Maher.
Hi, Dr. Ghafoor. How are you?
Fine, good.
An honor to
I could see Chand somewhere there.
Yeah, he is there. He is very much there.
And Rashid Al-Amri there.
Yeah.
Yes.
Hi there. How are you?
Salam, Dr. Rashid. How are you?
Fine, thank you. Thank you for joining us.
Hi, Abdul.
Great. Yeah, Chandji.
See you.
Great.
Hi, I think we'll begin now, Dr. Raman, in the interest of time.
Please.
Right. Good afternoon, good morning, good evening. We have guests from all over the world. And so I just say hello to everyone. On behalf of Sultan Qaboos University, Hospital Infection Society India, American Society for Microbiology, and Dash to Protect Antibiotics, we welcome you all to the International Symposium on Antimicrobial Stewardship and One Health. We are absolutely honored and delighted to have Professor Rashid Al-Abri, Honorable Dean, College of Medicine and Health Sciences, Sultan Qaboos University, as our chief guest. Thank you so much, sir, for finding time for us. We are also delighted to have two titans amidst us. One is Professor David Livermore, who is a doyen amongst microbiologists. Dr. Sanjeev Singh is really spearheading antimicrobial stewardship in a very big way in India, but he just phoned up and said that he won't be able to join because of some health issues. So we'll miss him. We are delighted and honored and humbled to have amazingly illustrious speakers with us. Professor Neelam Taneja, Professor Patrice Nodman, Dr. Manish Kaul, who will be delivering cutting-edge talks with us, And I'm totally humbled to have such illustrious moderators with us who will steer the talks. Professor Raman Sardana, Professor Chand Wattal, Dr. Abdul Ghafoor, thank you so much for your kind presence and for elevating this seminar to another level. Always very thankful to our valuable team members. Dr. Zaima is the organizing chairman, Dr. Renu Gur, a mentor plus dash PI, Dr. Victorian from Benin, Dr. Ujwala from India, Dr. Farah Al-Marzouk from UAE, and Dr. Ekadashi Rajani from India. Thank you so much for finding time for us and for doing such fantastic work with us. So once more, a very warm welcome. And just before we enter the proceedings, I'd just like to share this paper which recently got published. Christopher Murray et al. Talks about the death rates per 100,000, 2021. And actually it's slightly better than expected because the mortality in children under 5 has come down. But the areas of concern, as you can see, are the LMICs in sub-Saharan mid Africa. Everything else looks kind of better than what one had expected. But fast forward to 2050, and one can see that Africa seems to have got its act together, while South Asia, Southeast Asia, Eurasia, Eastern Europe, South America, something as expected is going drastically wrong. And we have expected forecast is 24 to 27 deaths per 100,000 attributed to AMR 2050. This is another paper of theirs published in 2020, and this kind of is a harbinger. This is third generation cephalosporin resistance Klebsiella pneumoniae, kind of a harbinger of what things would be in 2050. And what concerns one is that some countries we don't have data for. Crab is already such a huge menace, and it's actually scary when one sees that so many countries have more than 80% crab. And what is even more concerning is the number of countries has increased, those who are not reporting crab, and that tells us the state of the state of art, or at least a good standard microbiology laboratory, which is the need of the hour for promoting evidence-based medicine, for promoting good patient care, for promoting antimicrobial stewardship. We'll have Dr. David Livermore talking a bit more about the fallacies, even a good standard microbiology laboratory, how it can make so many fallacies. We have Professor Neelam Taneja, who will be talking about the One Health platform, the gains, the challenges, and it's heartening that the United Nations General Assembly has taken serious note of the AMR problem and has placed the One Health platform central to all our efforts in curtailing it. I just feel that we need one more subset, and which talks about microbial health. And I'm really, really very passionate about taking care of the microbes both within us, the good microbes within us and outside. We build a buffer, reduce infection in that way as well, and reduce AMR in that context. This is really a grim picture which tells us how difficult the One Health platform is going to be. And GDP is inversely related to vaccine coverage, to access to good quality antibiotics, to wash facilities, to AMR. And we really need global solutions, local solutions, all sorts of solutions to really address this issue. A recently concluded study by the DASH group showed exactly what we were suspecting, that the susceptibility profile of the standard antimicrobials is for UTI is significantly higher in the high income countries compared to the low and middle income countries. We do have some new drugs in town, and that's with such a sigh of relief, one can say that. But the spectrum leaves much to be desired, especially in the countries which have the higher end type of resistance. Access, cost, equity are always very, very important considerations for these high-end drugs. They are reserved, and we're so honored that we have Dr. Patrice Nordman with us, who will be walking us through the resistance. I mean, they've just come, and we're talking about resistance. And as we're talking, resistance increasing to these drugs. We also have enmetazobactam, a homegrown FDA-approved antimicrobial. Dr. Manish Paul will be talking about the challenges in developing drugs against XDR and PDR gram-negative bacilli. And when you're talking about sparing, or not despairing, but reserving the high-end big guns, I think it's necessary that LMICs also spare carbapenem, not just LMICs. I feel the whole world needs to be very mindful about how they're using or sparing carbapenems. And I'm so happy that ECMID And so many leaders are talking about sparing it, using piperacillin as a backbone for mild to moderate infections, OXA1 negative strains, and so on. And the DASH study is also trying to promote mindful, judicious use of antimicrobials. These are the centers who have so kindly agreed to work with us. We are uh, we are analyzing the data which we have got, and of course, nothing new here. We find that nitrofurantoin is by far the best drug around. Fosfomycin in those countries who are testing it. We would like to recommend fosfomycin in the Middle East. And of course, we do keep talking about how useful nitrofurantoin is because it works in ESBLs and so many MDRs, low collateral damage. Our wish list includes that we in Indian subcontinent and the Middle East start testing mesalinam, nitroxylin, tamoxilin, and fosfomycin. This is in-house study, and we found excellent outcomes and would love to translate this into the DASH work as well. And as I come from an LMIC, we know that it's so important to have phenotypic, cheap, simple tests to identify these resistance, and that's something we would like to promote as well. As well as, of course, if we get the funds, we would like to carry on understanding the molecular levels of resistance amongst our participating centers. The other aspect of our study is antimicrobial stewardship, where we really talk, we really go into the lion's den. We go and meet the clinical colleagues in their own seminars, where we have the HOD down to the intern or the first year PG. And it really lies on two prongs. One is the questionnaires, which allows us to understand what are the current prescribing practices. And then we go for targeted education. And as we must understand, I'm really passionate about our own flora, which call us home. And it's so important that we are very mindful and very caring and rather custodians of our microbiota, both within and without, green our environments. And of course, if we are mindful about the antibiotics we're giving, we need to understand also the collateral damage to us, to our patients, and how judicious use is important. And again, infection prevention control has such an important role to play. We come back, so this questionnaire, we need to thank Dr. Ken, and we analyze it, and we come back to the same clinical colleague seminar room, talk about appropriate prescribing vis-a-vis their responses, and of course share a local targeted antibiogram, and we try to get a consensus built. So we have many questionnaires, and I'll just walk you through a couple of them. So simple questions start beginning. What are the problems with AMR? How often do you experience it? So it was funny because community medicine actually said 84% of the times they see AMR, and medicine was slightly lower. But when we probed further, it's really a question of perspective. And while community medicine experienced it less often, less than a month, medicine was experiencing it monthly and weekly, and so on. The next question, again, a general question, is what is your usual empiric per oral IV antimicrobial therapy? And medicine talk was equally favored ciproflox, ceftriaxone, as well as amox and augmentin. And very few were looking at nitrofurantoin. So this again gave us very good clues as how to go about targeted education. And each department works differently. So we're working with obs and gynae, surgery, pediatrics, medicine, as well as community medicine. And you can see that obs and gynae is much more circumspect, just like pediatrics. They are majorly using cefuroxime, but again, nitrofurantoin is less, while they are really mindfully utilizing the antibiotics. And that gives us a very good way that we tailor our education according to the needs of that particular department. This is the crux of the questionnaire, where we actually we give them a vignette, and we ask them which is your first choice, second choice, third, fourth, and what should not be used. It's not an easy questionnaire, and I really thank all the participants who do that. And while they do that, a reflective prescribing is promoted, which is again one of our aims. I'll just share one little vignette with you. So there's a 64-year-old diabetic woman who presents symptoms of simple UTI. A urine sample is sent to the lab, luckily. So we always emphasize that please send a urine sample, one, so that we can build a appropriate antibiogram and not a skewed one. And secondly, if she comes back to you because of drug resistance, then you have the report ready. And the report, she came back, unfortunately, because there was no relief with amoxiclav, and the report said it was ESBL E. coli. The susceptible options were these, and I've always been very curious as to which drug will they opt for. And so the first choice, as I feared, I mean, this is just one of the groups. I'm not saying everybody does that, but there were many who talked about nitrofurantoin, but a much larger percent thought that they should opt for piperacillin and tazobactam, and much lower for Cipro and for trimethoprim. Second choice is usually more reflective. So in this particular case, it did not improve the choice because of ESBL, and I do believe we need to be very, very we should understand how nitrofurantoins work so well against ESBL. So you can see that ciproflox grew, meropenem came into the picture and gives us a good clue on how to teach. So when we come to the not to be prescribed, we always clap hands because we see that there's some people or several people who said they will not want to prescribe ciproflox, piperacillin, tazobactam, meropenem, and of course these are the areas we know we need to work on. Need to thank all the wonderful colleagues who fill the questionnaire and all the wonderful PIs who are always there and supporting us. It is not easy because we're all microbiologists. We're not really been trained in this, at least in the Indian subcontinent, but everybody has taken up the gauntlet and they're doing a great job. It wouldn't have been possible without our patron, Professor David Livermore, and all the wonderful experts associated with this study. And I need to thank our chief guest once again because he's always there. He has our back, and so happy to have you, Professor Rashid Al-Abri. And I welcome our organizing chairman, Dr. Zaima Al-Jabri, to please first introduce herself and then welcome Prof. Abri.
Thank you very much, Dr. Mihar. I am Dr. Zaim Al-Jabri. I am Associate Professor and Head of Department of Microbiology and Immunology in the Department of in the College of Medicine and Health Sciences, Sultan Qaboos University, Oman. Ladies and gentlemen, it's my distinct honor to welcome our esteemed chief guest, a distinguished leader and pioneer in the field of medicine and health sciences in Oman. Prof. Rashid Al-Abri is serving as the Dean for the College of Medicine and Health Sciences at Sultan Qaboos University. He is also a senior consultant in the ENT surgery with a legacy that has shaped our institution and impacted healthcare in Oman. He is a graduate of inaugural class of the College of Medicine and Health Sciences at SQU. He was awarded his MD in 1993, making the beginning of an exceptional career. He also pursued a postgraduate training in the United Kingdom, where he achieved his FRCS in 1999. And from 2004 to 2018, he led the ENT division within the Department of Surgery, establishing it as a leading center of excellence. And as a Director of Development and Quality at SQU Hospital, from 2006 till 2013, he introduced transformative quality initiatives and programs, elevating the hospital standards to international acclaim, yielded significant advancement, and he spearheaded the establishment of a comprehensive risk management program and improved healthcare and safety guidelines, quality management protocols, internal auditing system in SQH. These accomplishments actually garnered recognition from the WHO, which appointed him as the chair of the WHO Collaborating Center for Quality and Patient Safety Training in Oman. That was the first such center in Eastern Mediterranean region. And he further contributed to Oman Medical Education as the program director for the ENT residency program at Oman Medical Specialty Board from 2007 to 2016. And from 2016 to 2022, he served as the head of Medical Education and Informatics Department, where he played a key role in advancing medical education methodologies and integrating modern learning technologies. In his role as the head of medical education and informatics, Professor Al-Abri elevated the unit to an academic department. He expanded skills lab activity and introduced simulators for medical student training and played a key role in establishing online learning, aligning with the college new vision. Professor Al-Abri also is an esteemed academic and medical professional. He has published extensively with an H index of 24 over 12,200 citations, demonstrating his influential contributions and also international recognition in the field. of ENT as well. And of course, during COVID, he has numerous collaborative research initiatives, including COVID-19 studies with both Pan-Arab Rhinology Society and International Global Consortium for Chemosensory Research. And today, as we gather here, we also are proud of having Professor Al-Abri to celebrate with us this continued journey in the medical education and healthcare. We are privileged to be joined with this visionary whose dedication and accomplishment inspires us also. Please join me in warmly welcoming our chief guest, Professor Rashid Al-Abri.
Thank you, Dr. Zaima.
And thank you, Dr. Zaima, for this really introduction. And I would like to thank Dr. Rizvi for organizing both of you this important meeting actually to Oman. And I would like to welcome all of our colleagues who are joining us today in this important meeting. Also, I'm really would like to see a lot of research coming out of this meeting as a collaborative research between this group and Sultan Qaboos University. I'm happy to support all the initiatives coming from your department, Dr. Zaima, Dr. Maher Rizvi, on aspect of antimicrobial, as it's very important to our community and also important to our generations who's currently now, especially in public, as you know that they can get the antibiotics from different centers, and they develop resistance to such antibiotics. But I'm really happy to be with you today and to start this journey. As a Dean of the College of Medicine, I would like to welcome you all as a faculty, and we hope to see you here in Oman as per your request. I will try to make this dream happen with Dr. Zaima and Dr. Rizvi around, and hopefully we'll see you here at least for a couple of days in the coming couple of years, or as individuals. So I would like to welcome you to this important meeting. And please take my support and the colleague support for this collaboration. And I would like you to continue in the future for the best for medical education and for the health. I'm really also would like to repeat the one Dr. Rizvi statement. He mentioned that there's no sort of health. Always we say in the quality and education, there's no quality, there's no escape from quality. I can say today there's no escape from antimicrobial also. And we are at One Health. So wish you all the best in today's meeting. I'm trying to enjoy some of the lecture, hopefully, in the coming couple of hours. So thank you. And then thank you, Dr. Zaima and Dr. Rizvi for this meeting. Thank you.
Thank you, thank you.
Thank you,
Thank
Prof.
Yeah, thank you, Prof. Abri, for that such wonderfully encouraging words. And I hope that we are able to fulfill your expectations from us and your dreams for us. And quality, as you said, is really, really the benchmark which we would love to establish in SQU as well as with our study. Thank you so much for finding time for us and for your encouragement. Ladies and gentlemen, we're thankful once more for Prof. Abri's encouraging words. And now we are more than happy and in fact honored to have Dr. David Livermore give us his address. And to welcome him, we have Principal Investigator Team Dash from Benin, Africa, Dr. Victorian Dugnan. Dr. Victorian, will you please first introduce yourself and then welcome Dr. David Livermore.
Thank you very much, Prof. Meher. I'm Victorien Douillon. I'm an associate professor in microbiology at the University of Abomey-Calavi. I'm also the American Society for Microbiology country ambassador to Benin, and I work on many projects related to antimicrobial resistance and the valorization of African flora. So it's my great honor to introduce Dr. David Livermore, who is a retired professor in microbiology at the University of East Anglia at the United Kingdom. Prof. David Livermore began his career in 1980 as research assistant at the then London Hospital Medical College, writing a PhD on the side. By 1994, he had risen to senior lecturer in medical microbiology, and 3 years later, he moved to the Public Health Laboratory Service, now called the UK Health Security Agency, swiftly becoming director of its antimicrobial resistance monitoring and reference laboratory. He remained until 2011, when he moved to the University of East Anglia as professor of medical microbiology. Now, semi-retired, he returned an honorary professorship with the University of East Anglia and consults widely for the medical industry on antibiotic development and rapid diagnosis. Across 40 years, he led teams that define the evolving epidemiology and nature of antimicrobial resistance in the UK and internationally. This is really a great honor to host Prof. David Livermore. Thank you.
Right. Thank you. Thank you so much, Dr. Victorian.
Well, ladies and gentlemen, many, many thanks indeed for the kind invitation to speak today. It's always a pleasure to give this address as the patron of the DASH group. And I should start off really by congratulating you all and congratulating Maya in particular on so much hard work done these past 12 months. So much has been achieved in terms of networks built and data collected. That, of course, brings its own challenges, because as we seek to collate data, to look regionally at prevalence of resistance, we see all sorts of anomalies. And what I want to talk of today is how we must always, as we look at data, ask that one critical question: what's going on here? It's vital that the folks who are contributing data do this, that they look critically at their data, and that we, Mayor in particular, centrally, also look at that and ask that question: what's going on here? It was a question that I've taken from a book, Radical Uncertainty, by John Kay, who's an economist, and Mervyn King, who was previously the governor of the Bank of England during the financial crisis of 2007 to 2008. And he writes, "The question, what is going on here, sounds banal, but it's not. In our careers, we have seen repeatedly how people become immersed in the technicalities, engaged in day-to-day preoccupations, and have failed to stand back and ask, what's going on here? We've often made the mistake ourselves. And I have, as a scientist as well. And it's absolutely critical as we push DASH forwards that we keep asking these data, this question, particularly as we see more unusual data. And I want to try to exemplify this with some of the data that DASH has recently shared with me. Now, the data which I'm going to put up on screen in a moment, they're all from E. coli, they're from various participating centres. Now, I know from experience and a knowledge of mechanisms that for E. coli, you should always see more resistance to first generation cephalosporins than to second, than to third, or to fourth. You should always expect to see more resistance to cephalosporins of any generation than to carbapenems. And because there's more enzymes that modify gentamicin than amikacin, you expect to see more resistance to gentamicin than to amikacin. And because it's an inherently less active antibiotic, you expect to see more resistance to coamoxiclav than to piperacillin tazobacter. So those are my preconceptions and my expectations. And whenever I'm asked to look at a data set for E. coli, I start with those in mind, and I'm struck whenever I see a difference from them. We'll come to why those differences may exist a few slides hence, but let's look at a few examples first. These are data for Oman, 13 centres, many thanks to everybody who's participated. And I've highlighted the cephalosporins in yellow. Now, as I say, I expect to see more resistance, these are actually susceptibility, so less susceptibility to first generation than to second generation, to third, to fourth. So let's have a look at this top row. Cefazolin, lower susceptibility than later generation cephalosporins. These three rather equal. Well, if it's all extended spectrum beta-lactamases, that's not too surprising. But there's something strange about this 16% susceptibility to cefazolin, because it's lower than the susceptibility to ampicillin. Now, everywhere else that the two drugs are tested, cefazolin has higher susceptibility. Strange. What's going on here? Now, Oman 7. Lower susceptibility to cefazolin and cefuroxime than to ceftazidime and ceftriaxone. That's what I'd expect, but very much higher susceptibility, 90% to cefepime. That's different to almost all the other centres. I can think of a mechanism, a high prevalence of AMP-C beta-lactamases that would give it, but I would like to see that mechanism confirmed by direct examination of some isolates. Here's another anomaly. Oman 8. Ceftazidime, 80% susceptibility. 17% higher than ceftriaxone. Now, given that most of the resistance you would expect would be extended spectrum beta-lactamases, that's a very large differential in ceftazidime's favour. It surprises me. And then look at cefepime, down to 48%. How can we have almost twice as much susceptibility to ceftazidime as to cefepime? That's very unusual. Here's the other extreme. Cefazolin 35%, second, third generation cephalosporins all around 50 to 60%, all looks very reasonable. But then cefepime down at 19% susceptibility. That's incredibly low. Were there really a lot of isolates that were resistant to cefepime but susceptible to these other cephalosporins? If so, that would be quite exceptional. And then move away from the beta-lactams a moment. You expect higher susceptibility to amikacin than to gentamicin, and for Oman 13, and more narrowly for that matter, Oman 12, you've got the opposite pattern. What's going on here? Let's move to the Indian subcontinent. Now, the slide here is a mixture of Indian, Pakistan, Bangladesh, and even Maldives centres. You expect more susceptibility to carbapenems than you had to cephalosporins, but subcontinent 2 here has the opposite pattern. Now, I believe they're carbapenem results because they've got remarkably similar results for both carbapenems. That increases my confidence. But how is there more susceptibility to cephalosporins than to carbapenems? Is there a big proliferation of OXA48 carbapenemase, which attacks carbapenems but not cephalosporins? I can think of a mechanism, but to see it on that scale would be exceptional, and I would want to see molecular confirmation before I published. Here again's a differential between two cephalosporins. Cefuroxime, 76% susceptibility, ceftriaxone, only half that, 39% susceptibility. That's unusual. I would be hard pressed to think of a mechanism that would make an E. coli susceptible to cefuroxime but leave it resistant to ceftriaxone. I can't think of anything that would do that. Here's another. We saw a site in Oman which had an unusually high percentage susceptibility to ceftazidime compared with ceftriaxone. Now we've got the reverse. There are ESBLs that preferentially attack ceftazidime. They're not very common. Perhaps this site has a lot of them, but it's unusual. One has to ask that question. What's going on here? We must confirm it before we can be confident. Again, a site with more susceptibility to gentamicin than to amikacin, as in Oman. That's unusual. And in general, look at the figures. Coamoxiclav, if you can't see the header for me, is this column, and piperacillin tazobactam is this column. And you see typically that there's about 20% more susceptibility to piperacillin tazobactam than to amoxicillin clavulanic acid. But this centre's a real outlier. 3% only susceptibility to coamoxiclav, but 57% to piptazole. Not impossible, but unusual, as is this one with near equal susceptibility and high susceptibility to both penicillin inhibitor combinations. Again, we need to look and ask the question, what's going on here? Now, in 40 years of working in laboratories and 20 years of heading laboratories, what I've learned is that when you get an unusual result, there are three explanations. There's a testing problem. So you look at the controls. Did they behave normally? If it's your data, you can eliminate the second problem immediately. But if you collected somebody else's data, you have to think very hard about it. Selective testing. Remember that centre that had much more resistance, lower susceptibility to cefepime than to third generation cephalosporins? Well, perhaps they only test cefepime against isolates that, let's say, are resistant to cefotaxime and ceftazidime. And they find most of them are resistant to cefepime as well, but a small minority are susceptible. That might explain what we've just seen. But what it does, if that's the case, it does mean Mayer and team cannot simply pool those data into a general rate of cefepime susceptibility. And the final possibility is that there really is an unusual resistance epidemiology. That site in India I highlighted with more resistance to carbapenems than to cephalosporins really does have a massive proliferation of, let us say, OXA48, sometimes in strains that haven't got an ESBL. But you really have got to ask always what's going on here and really tease the data apart. Be sure of it, do additional tests where necessary. And I learnt my lessons the hard way when I joined what was then the Public Health Laboratory Service in 1997. One of the most remarkable things I saw was that we had a system for collecting data on the susceptibility of bacteremia isolates. Every country, every hospital, forgive me, up and down the country reported the susceptibility of their bacteremia isolates to us. Now, I knew that there were a few very, very rare reports of ampicillin resistance in Enterococcus faecalis. But I was startled to see that 10 or 20% of the reported Enterococcus faecalis were ampicillin resistant. And I thought, is there a massive outbreak that we know nothing about? And then I looked a bit more and I got some of these isolates and I realized they were all really Enterococcus faecium, not Enterococcus faecalis. And until we moved to MALDI-TOF identification, this was a persistent problem in the UK. So in the data that are coming in to DASH, and thank you all for them, thank you for your contribution, there are anomalies. These are anomalies that you, who know these data better than anybody, can best help to sort out. Is it a testing issue? Has there been a problem? Or is it selective testing? If it's selective testing, please let Maya and the team know. Or is there really something unusual in the epidemiology of resistance at your site? So let us work collectively to a great effort to ask what's going on here. And I'm more than happy to participate in teleconferences to discuss any site's antibiogram or antibiograms from different sites as they come in and are put into tables that might form the basis of papers, because we need to sort these sorts of issues out before we publish. And if you think you have challenges here, let me end on something quite different, but quite fascinating. These are data from the Czech Republic in Central Europe. They were obtained under a Freedom of Information request, which led to the release of a massive amount of anonymized patient-level data showing which vaccines a citizen had had for COVID and what happened to them over the next year or two. And a man called Steve Kirsch, who is a tech he's not a biologist or a medic, but he's a tech entrepreneur who is rather skeptical about COVID vaccines, much more so than I am, did a wonderfully simple analysis. He simply looked and said, well, you get one or other of these vaccines, and it's pretty random which one you get. But whichever one you get for the first shot, you tend to get for the second and any subsequent shots. So, majority of people got Pfizer, a large minority got Moderna, and there was no real pattern to which one they got. So he asked the question, you get vaccinated, how likely are you to die within 1 year? Simple question. Can't fake death, or at least not very reliably. And what he finds is if you're in your mid-40s and you had the Moderna shots, you're 1.5 times more likely to be dead within a year than if you had the Pfizer product. And that differential persists right up to an age of 100. More likely to die if you've had the Moderna shot. Now, this is nothing to do with the vaccine's efficacy against COVID, because the people who die of COVID are up at this end of the graph where the differential is narrowing. This, one has to fear, is something much more to do with vaccine side effects. And there's a plausible explanation in that the Moderna vaccine carries a much higher dose of messenger RNA, about 3 times higher than the Pfizer product. And there's some evidence that the spike protein in the bloodstream of itself is toxic. Now, it's quite possible still that there is a totally innocent explanation of these data, but they've been in the public domain for about 4 months now, and I've not seen any innocent explanation. So one really has to keep asking, what is going on here? This slide should be up at every scientific conference in the world, which is why I've put it up here with that question. What's going on here? We mercifully for Dash only have simple questions of antibiograms to sort out. This is much more charged. And with that, I'll leave you and wish you a great conference and look forwards to looking at data, asking questions and producing good publications from it. Thank you.
Thank you so much, sir, for that insightful talk. And I was feeling very red-eared with all the huge errors which we made. And that's where exactly one needs a mentor. That's where exactly we need somebody with oversight who can look over your shoulders and see what you can't see. And I really firmly believe in that. And I'm so thankful that we have Dr. David Livermore, who gives us his time. You know, the biggest currency these days is time. And for us, looking at just simple antibiograms, and I thought I'd done a good job, and then you heard what happened. So thank you so much, Prof. David Livermore, for giving us that valuable time and for making us understand the errors of our ways. Thank you once again. And ladies and gentlemen, we're ready for another fabulous talk. Unfortunately, as I told you earlier, that we will not be able to hear our second guest of honor because of a family emergency. I'm sure we'll hear from him some other time. Now we're ready to hear from our first distinguished speaker, Professor Neelam Taneja, who will talk about gains, challenges, and the way forward in tackling AMR through the One Health platform. We are so honored to have Professor Raman Sardana, who will moderate this very important session. And to welcome him, I welcome Professor Ujjwala Ghoshal, a dynamic microbiologist in her own right. Professor Ujjwala.
Good evening, everyone.
Introduce yourself. Yeah.
Yeah, am I audible?
Yes, absolutely.
So at the outset, I would take this opportunity to thank Meher for this opportunity. I am currently working as a professor and head in the Department of Microbiology, All India Institute of Medical Sciences in eastern part of India. It's near Kolkata. And prior to that, I was working as a professor for last 23 years. I was working in northern part of India in Sanjay Gandhi Postgraduate Institute of Medical Sciences. We are involved with patient care, teaching, and research. And antibiotic sensitivity is one of a major area of interest. And for past 2 years, we are working with the support of the government of India. We have also started working on One Health. It's my pleasure and honor to introduce Dr. Raman Sardana, who is working as a professor in clinical microbiology and infection control, Apollo Hospital, Delhi. He is the director, board of trustees, the FIIS UK, and honorary secretary, Hospital Infection Society of India. He is a member committee on hospital infection control and biomedical waste bureau of Indian standards. He is a member Government of India expert group on National Patient Safety Implementation Network. He is a member TWG Bloodborne Viruses and Dialysis, NCDC, Ministry of Health, Government of India, and he has been awarded with the Prashasti Patra by Government of Delhi for Pulse Polio program in 1995. He conceptualized and instrumentalized the Guinness World Records on hand sanitization relay, 5th May 2016 at Indraprastha Apollo Hospital, Delhi. That is the first record established by India. He is the recipient of Scroll of Honor from Delhi Medical Association and other non-governmental agency for his contribution in community health projects. He has co-authored National Treatment Guidelines on Infectious Disease, National Patient Safety Network implementation Framework, Government of India, National Action Plan, Combating Viral Hepatitis in India. He has more than 67 publications and he has authored and co-authored in 14 prestigious book chapters. He is a teaching faculty in microbiology and clinical and nursing specialty for past 32 years and has guided and co-guided more than 48 postgraduate theses in different specialties and directed more than 104 postgraduate research projects. So I would now request Dr. Raman Sardana for his presentation. Sorry. Dr. Raman Sardana, please.
Thank you, Dr. Ujjwala. Welcome, Dr. Raman Sardana, to please take the stage.
Thank you, Dr. Ujjwala, for those very kind words, and thank you, Dr. Meher, for giving this opportunity once again to collaborate with DASH and with ASM and with Sultan Qaboos Hospital, University Hospital. Really indebted to all of you for this collaborative effort internationally. Now, Professor Neelam Taneja, if you people who know her profile very well. In fact, she doesn't need actually an introduction, but some formalities. So she's a professor and head at PGMR Chandigarh Medical Microbiology. She is a nodal officer for ICMR Coordinating Center on AMR, and she's also a member of WHO Advisory Group and very well known, in fact, on bacterial priority pathogen lists. Expert member of many national and international organizations like ICMR, DSDBT, BIRAC, WHO consultant for Nepal, ICMR. You name the organization which are active, very actively involved, and she is into it. And not only that, she is well revered there for her work and contribution. She has received numerous awards globally, as is expected, and that includes fellowships from WHO, Cancer Institute, International Development Award for Young Women Scientists, and also has got more than 240, so about 250 highly peer-reviewed articles. Very well read those articles. Some of them actually are very, very relevant to what we are talking today on. And areas of interest, as you would have guessed by now and would have seen by now, is AMR, One Health, enteric infections, HAI, and UTI, all the current topics which are targeted and focused upon by world organizations at the moment. So without taking any more, I'll come back with after the talk or something which need to be said about One Health and how people in the world are taking World Health. Dr. Professor Neelam, over to you, ma'am. So, and the audience.
Thank you, Raman, for this kind introduction. And I would like to thank Meher, who is my very important collaborator, I would say international collaborator, who invite me to give this talk. This is an area where I have been working for quite a long time when this entity One Health was also not there. So I have, can I share my screen if I'm audible?
Yes, ma'am, you're audible.
Yes, ma'am, please share.
Okay, in case there's something wrong with the, I don't know whether I'll be able to share from my laptop or not.
You want me to share? Okay.
That's why I sent my PPT.
Okay.
So if you can share from there and we can be.
Sure. Can you see the screen, ma'am?
Yes, I can see the screen. Others can, yeah. So, yeah. So we all know that AMR is a critical global health issue. In fact, we have already started seeing that in 2019, there were 1.27 billion global deaths attributed to it, and 4.95 million deaths associated with AMR. Currently, AMR is killing more then HIV, AIDS, tuberculosis, malaria combined. And by 2050, it is expected that it will lead to a reduction of 2 to 3.5%. And even the livestock production will fall by 3 to 8%. And the cost is going to be enormous. But AMR is also a problem of inequity that is going to affect the marginalized and poor societies rather than the affluent world. So we in Asia and African continent are going to face the maximum impact of this. Next, please. So AMR does not have any geographic or human or animal borders. And this is well exemplified the example of MCR1, which spread all over the world. Next, please. And this is, AMR is also a global food security issue, food safety issue. Of the 41 antibiotics which are currently being used on the animal health side, 31 are also used in the human health side. And there are no new discoveries on the horizon. On the animal health sector, the antibiotics are used for disease prevention, to contain outbreaks, as growth promoters, and prevent contamination of food chain. So this shows that the crisis of AMR is dire. Next, please. And these shows the predictions by 2030 that the global trends in antimicrobial use in food animals is going to rise by a staggering 67%. And if you see the upper picture, most of this is going to happen in India. Next, please. So India is I would say, the hub of AMR or capital of AMR in this world, and also the region of South Asia. So if we see, there are certain most important risk factor to spread of AMR is basically the consumption of antibiotics on the human side. So this consumption is increased. The consumption of broad spectrum antibiotics is increasing in India, whereas the production as well as the consumption of narrow spectrum antibiotic is going to decrease, is decreasing very fast. In fact, some of the narrow spectrum antibiotics are very difficult to get in the market. Next, please. So these are the causes of AMR crisis. You must have seen these information, which must have been repeated many times. Apart from this overprescribing of antibiotics, we have other factors like patient not taking antibiotics as prescribed, unnecessary antibiotic use in agriculture, poor infection control in the hospital, poor hygiene and sanitation practices, and also lack of rapid lab testing. Because these tests are not available, it is very difficult to differentiate the viral causes from the bacterial causes. In fact, we did a study in which we made a decoy patient, and the decoy mother, she went to the chemist in Chandigarh and nearby regions, and she said to the chemist that my son is not well and he's having URI. Can you prescribe some medicine? 50% of the time, the antibiotic was prescribed by the chemist without even any prescription not asking any prescription from a physician. In rest of the 50%, the decoy mother, she asked that my son is really unwell. I'm not able to go to the physician. Give a strong medicine. So in 30% more, the chemists, they gave her antibiotics. And last 20% of the cases, the mother said that, no, I want antibiotic for my son. Can you give me some antibiotic for my son? And you won't believe that we were shocked when we found this finding, and we're going to soon publish it. In 100% of cases of URI, the chemists gave the antibiotics. So this shows the availability of antibiotics over the counter and overprescribing of the antibiotics and patient demanding the antibiotics. Next, please. So the spread of AMR, it is very important to understand if one wants to understand the impact of One Health, how One Health is going to impact us. So antibiotics, whether it is taken by humans or by the animals, they all come to the environment. And environment is a big reservoir. Now you must be wondering if taking an antibiotic, how it is going to affect the society, how it is going to affect our health. If a person has taken antibiotic, you know the normal flora gets killed and the organisms in the gut, there is collateral damage and they become resistant to these organisms. Now this person comes to a hospital, he has a like we did some study in which we found that 100% of our guts, they're colonized with ESBLs. And we have quite a lot of cases, we have carbapenem resistant enterobacterials in our normal healthy individuals. So when this person falls sick and goes to the hospital, these resistant bacteria, they will spread to others, can spread to others. Similarly, the animals which have been given antibiotics, they have edible antibiotic resistant bacteria in their gut. And these drug resistant bacteria, they actually can survive on the meat or on the food which are contaminated by the contaminated agriculture soil. And these bacteria can, again, they can reach us through contaminated food. Next, please. So this is what the diagram which is showing that 80% of the antibiotic which we take, it comes to it's excreted from feces and stool. And similarly, all the antibiotic which is being used in the agriculture, it will come to the environment through runoff or through if it is being used in the animal sector. We have found that in Baddi region that the intense farming is there, poultry farming is there. So the poultry and lot of antibiotic is being used. Even the farmer does not know. The poultry farmer does not know that so much of antibiotic is being used, and the sewage or the effluent from the farm is going to the fishery because this is rich in nutrient. So using aquaculture. So all this is coming to the environment. Next slide, please. So environment becomes a big sump. Okay, it not only has antibiotics, it also has drug-resistant bacteria. Now these bacteria, even if they are susceptible, they are sensitive. The pressure in the effluent it may not be the MIC levels, so it is not killing the bacteria. So it is too low to be lethal to expose, but it is sufficient to induce antimicrobial resistance. And there are a vast array of contaminants in municipal and industrial wastewater. We recently did a study in Baddi, which is a pharmaceutical hub, and we were shocked to see the amount of antimicrobials in the wastewater. And we found that the hotspot of these drug-resistant bacteria was hospital sewage, the community sewage, and the pharmaceutical effluent which was coming. And this pharmaceutical effluent was contaminating the community sewage. Next, please. So One Health is very important because 6 out of 10 diseases are zoonotic in nature. And animals are host to countless pathogens. There is extensive deforestation, which increases the risk of exposure to humans and livestock to new pathogens, leading to emergence and re-emergence of microorganisms. And the environment is getting contaminated like anything. Next, please. So this is the concept of One Health. One Health says that we have to have healthy human, healthy animals, and healthy environment. So this is a collaborative approach. It is a coordination between the 3 sectors. It is a holistic view. It's a unifying concept, and it's a shared responsibility at the local and national level, regional and global level, and it will lead to the sustainable development of a healthy ecosystem, healthy animal, and healthy humans. Next, please. So WHO, the FAO, the OI, these are the 3 initial organizations which made a tripartite arrangement of One Health and gave One Health. And along with it, the United Nations Environmental Program, they formed the One Health high-level expert panel, and they have taken out many important initiatives, one of which is critical is Global Action Plan on Antimicrobial Resistance by WHO, and all countries are supposed to make their own national action plans. And the first group which was created, I was also part of this, that's the WHO AGSAR group. Next, please. So you would ask, what are the gains through successes in combating AMR through One Health initiatives? Canada is one country where I went and saw their One Health website, and I was impressed. They had everything there. So I encourage all of you to go to their website on One Health. The first and most important success or gain will be a coordination. We cross-talk. We start talking to intersectorial talk, intersectorial coordination, improved surveillance at human and animal and environmental interfaces, then responsible antibiotic usage, not only in human sector, but also in the animal sector, control of this effluents in the pharmaceutical industry, and prevention of the contamination of the environment. It leads to innovative partnerships, innovative solutions, and policy advancements. Next, please. So if you see that this One Health concept, it will prevent outbreaks of zoonotic disease in animals and people. It will improve food security and safety, reduce antimicrobial resistant infections, improve human and animal health, and protect global health security and protect biodiversity and conservation. So this is also very important. Next, please. So this is the WHO AGSAR, integrated surveillance of antimicrobial resistance in foodborne bacteria. If you're interested in doing an integrated surveillance, this is a wonderful document to have. And this also talks about monitoring surveillance of antibiotic use and also how to do analysis and reporting. Next, please. So can you make a click? Can you click? So these are the first project countries. So I had the privilege to be the lead for India AGSAR project. Next, please. So you can see quite a few countries in the lower middle income countries, they were part of the WHO AGSAR projects. And if you see, this is one example that I told you about the Canada example, how restricting the antibiotics in the animal sector will help the human health. So in this, what happened was that in Canada, Quebec, the ceftiflor is a third generation cephalosporin. So in Quebec hatchery, they voluntarily removed this third generation cephalosporin, and they found that the abattoir chicken salmonella, retail chicken salmonella, and the human non-typhoidal salmonella, which were ceftriaxone resistant, their incidences, they went down. Okay. So, but humans are humans because it was voluntary. So people again started using this then they banned it completely in 2014. And then you can see the gray bar showing the ban. And you can see that all these the percent of flocks reporting use of ceftiflor, you can see, and that came to 0%. And there is a corresponding decrease in abattoir chicken salmonella, retained chicken salmonella, and human non-typhoidal salmonella species. So this is how the power of stopping one antibiotic in the animal health sector, which impacts the human health. So if it was only salmonella, next slide, please, then we could have thought that, okay, this is salmonella. But similar findings they showed in E. coli. Next, please. So this is our own study. This was the largest surveillance done anywhere in the world. We took more than 2,000 human samples, and the same corresponding area, we took animal samples, animal intestine contents, stools, cloacal swabs from poultry, from livestock in our North Indian region. And this salmonella, which is Salmonella enterica, Serovar Kentucky, ST198, This is the predominant strain which is circulating right now, and this causing acute gastroenteritis in our region. And we did a whole genome sequencing, and we found that it's very, I'm not sure which is very it's clear, but we found that, next slide, please. We found, these were the key findings. We found that chicken and goats, the strains, they were separate clusters, suggesting that they circulate independently from each other. But many cases we identified, we could trace it to the farm, where chicken and goat clustered alongside human isolates, indicating a possible transmission between humans and animals, potentially via the consumption of contaminated food, contacts with animals. Additionally, we showed that some examples where human and non-human strains isolated from India clustered together with isolates from UK, suggesting an epidemiological link to international travelers between India and UK. So this is the power of One Health, power of genomics in One Health, that you can go to the farm level and trace. Next, please. So coming to some of the challenges. The biggest challenge in utilizing One Health is the fragmented efforts. You know that we have different ministries dealing with, in India, we have different ministries and government agencies dealing with these, that we have a separate environmental ministry, agriculture ministry, health ministry, human health ministry. So, and there is no cross-talk, they're working in their silos, and there is no cross-talk happening between, and there's lack of systemic surveillance systems for all three sectors. Next, please. So apart from this silos approach, I tell you that we in the human health sector, we get paid pretty well, but the infrastructure on the animal health side, the payments, the workforce capacity, the capacity to look for antimicrobial resistance, to isolate the organisms, because we conduct many training programs for a veterinary sector also. So there's insufficient funding. So this sector is lacking. And this complex coordination which is required, because I have gone to many L1 health meetings, and they say that human health sector accuses the animal health sector that we are spreading the resistance, whereas the maximum antibiotic usage is happening in the human health sectors. So these are very complex situations and complex challenges. Next, please. So then there are competing economic interests. I'm giving examples of between public health and agricultural productivity. If the farmer to use an antibiotic is an economic incentive, because he is going to lose always, if he gets a Salmonella typhimurium infection in the poultry chicks, his whole farm is going to, all chicks are going to die. So this is an economic requirement for him. It is, he will, because he's not a very rich farmer. Even if he's a rich farmer, he would not like to lose money. And then there are data gaps, insufficient data on AMR prevalence and antibiotic use across regions. In fact, there is hardly any data. It is very difficult to capture antibiotic usage data in the livestock sector. Next, please. So way ahead, challenges are many. So I was the mentor for this meeting and steering committee member for this. So this was between UK, Academic Medical Sciences, and ICMR, and we actually brainstormed with a way ahead. Next, please. So I will show you some of the important points, and this policy guideline is going to be published soon. So we said that we embed AMR as part of broader public health agenda and intensify investment in an access to interventions that reduce infection rate in human and animal. For long, we have considered AMR in isolation, so it should be embedded with the broader public health agenda so that we can integrate antibiotic stewardship, we can infection control practices, and the WASH activities. Next, please. This is basically for the Indian context I'm talking about. And these are the actions to be prioritized, that we need a leadership from government governing bodies and coordination across multiple sectors. And these structures have to be created spanning human health, animal and environmental sector at subnational, national, and international level. They should need sufficient funds, and cross-sectoral governance is very important. Next, please. So next action to be prioritized is to develop a national regulatory framework to ensure appropriate use of antibiotics in humans and animals. So we talked about access and excess. Both are important because certain parts of the country may not have access to the antibiotics. So these need effective systems to monitor antimicrobial use and robust data collection and routine evaluation of antimicrobial effectiveness, which all microbiology labs are doing, is paramount importance. Next, please. So you will be surprised to know that people talk about tertiary care referral center. So I work at primary health care, and I tell you 50% of the, because there is hardly any diagnostic setup they have. So 50% of the persons who are coming to the primary health care center, they are actually prescribed an antibiotic. Even if the illness could be viral. In most of the cases, it would be viral. And rapid diagnostics and treatment selection at point of care. We require point of care tests. And also, in looking at the India's ITR capacity, aided decision support tools, computer aided decision support tools, which we piloted in one of our ICMR FIND trial, they actually reduce the antibiotic usage quite a lot. Next, please. So, on the veterinary sector, it is very important that we have to expand this activity, veterinary capacity, strong focus on optimizing interoperability, creation of multi-stakeholder collaboration to identify implement antibiotics.
Ma'am, we can't hear you very well.
What, something went wrong?
No, it's fine.
No,
Now it's fine.
now it's coming. We can hear you. Now I can hear you at least.
Okay. So the National Dairy Development Board, they conducted an ethno-veterinary project, and where they used plant-based products like garlic and some herbs for common infections rather than antibiotics. So these are the kind of initiatives which are needed on the animal side. Next, please. No, research, definitely we need genomic research. We need to develop a system-based analysis to identify potential policy levers and points of intervention for AMR action, and integrate more economic modeling into AMR frameworks to inform AMR research and decision making. If you economics is very important. If one can actually make a case that okay, you're spending this much money, but these are going to be your economic benefits. So this is very important. It goes very well to convince the politicians and the funding agencies. Next, please. And this is the most important point I would like to say, that we conducted a DBT UKRI project, winning project, in which we found it very difficult to, as a microbiologist, I found it very difficult to how to communicate with the farmer. So thankfully we had a very good social team. So it is very difficult. We have to learn their language, how we speak with the farmer, how we tell that farmer that antibiotic usage is going to be harmful. It is going to be harmful for your health, and ultimately, because this is not a kind of a immediate benefit. He will understand. Immediate benefit is economic. He wants to save his chickens and all that. So this is the area where I say the interdisciplinary research is very important, and it is a big role of social scientists here. So this research has to be highly context specific, because every country has a different problem. Even India, I would always say India is not one country. It's 27 countries, in one country. So there are regional issues, there are ethnic issues, and all need to be addressed, and they can be addressed best by the social scientists. Next, please. So what is needed? We need policies, stakeholder engagements. We also need innovations in diagnostic and treatment. Next, please. I will go fast now because this is quite a lot of repetition. But one of the very important initiative has been GLASS. This WHO launched this global antimicrobial resistance surveillance system. Now this integrates the surveillance data on antimicrobial use in humans, tracks antimicrobial use, and understand the role of AMR in food chain environment. So this is quite a lot of countries are actually putting their data into the GLASS, including India. ICMR is the nodal agency who actually, we have a network of ICMR network on AMR, and I'm the nodal officer for the ICMR AMR on enterobacterales, and we submit our data to ICMR, and ICMR submits that data to GLASS. Next, please. Then another is the critical priority pathogen list, which actually guides research and development for new antimicrobial diagnostic tool and vaccine. It took us 2 years to develop this list, and the new list is out. And then WHO has partnership with DNDi to introduce new antimicrobials in LMICs. Next, please. So, awareness. So this is the World Antimicrobial Awareness Week. It's a global campaign to raise the awareness of AMR worldwide, to encourage best practices among the general population, healthcare workers, and policymakers to curb the evolution and spread of drug-resistant infections, and sustained involvement of media all around the year is essential. So not only during the war week, but we need to be a sustained. And this mass media can be a very powerful tool. And we also recommended that the AMR awareness should be started in school and should be part of the curriculum of the school children. Because children are the best to teach their parents. And we have always been reactive, but now we need to be proactive to strengthen the surveillance and monitoring system, and we have to make evidence-based decisions. Next, please. And foster collaborative research and innovation by developing novel antimicrobials, improved diagnostic, and data-driven insights. Next, please. And this is a very weak area. We have all the kinds of policies, but hardly any implementation. So implementation of the policies should be such that they should be implemented. But one has to provide incentives. Like one has to provide incentive to the farmer. One has to provide that if he uses an alternative to antibiotics and if his chicks die, he has larger losses. So there should be some kind of compensation to the farmer. Only then the farmer is going to agree. Similarly, the pharmaceutical industry also needs to have incentives or cheaper alternatives so that their antimicrobial effluents do not come out in the environment, do not pollute the rivers. Next, please. So we have to build a resilient and sustainable One Health ecosystem. I recommend you to go to Canada website, and it has all these components: capacity building, stakeholder engagement, sustainable financing. Very important that unless we have funds, and funds are actually they percolate down to the actual person who needs that fund. We may keep on talking about One Health. The results will be very slow the gains will be slow to appear. Next, please. So this is my last slide, a thank you slide, and saying that I would say now we have a long lives now, thanks to good cancer management, chemotherapy, so many surgeries. All this has been possible because of antibiotics. So without effective antibiotics, attaining universal healthcare and sustainable development goals will not be possible. So we not only have to develop new, but more important is we have to preserve the ones we have, and prevention is always better than cure. So this is, we need to act, and everybody, right from the society, human health sector, animal health sector, environmentalists, everybody has to come together in real One Health scenario, because we have our human health is integrated with the animal health and environmental health, and we are living in an interconnected society, interconnected planet, and we have to come together so that we can mitigate the effects of AMR. Thank you so much for patient listening.
Thank you, Dr. Niyam. As always, your content, your hard work on ground, and your assimilation of various studies, and your first-hand experiences, they form the larger content of your talks everywhere, and that's what people are looking for, somebody who's on hands with Now, coming to One Health, I think the biggest challenge that you, I think, want to mention but did not mention was that the biggest challenge is Homo sapiens sapiens. It is, I mean, the mankind, in fact, because we create chaos and mess. We are masters at that. And then, we try to meddle in finding solutions to that and then create more mess. And then we formulate all those, we think, we get all the experts together and try combating the mess that we have created, and then claim some certain amount of success in certain pockets. And in return, what we get is much more chaotic than what we began with. So my thing is that it is something which we need not interfere and meddle with nature as such. I'm very sure that yes, certain things need to be done in human health. Certain things have to be done in animal health, especially the domesticated ones. But I think it's time that we lift the environment as such. Don't disturb it. Growing populations, human populations, the climatic changes that we have brought with introduction of so many things, and the movement of humans and animal products, they all have contributed specifically for this, in this aspect. And I don't think that One Health should only be used. It's almost like a 2 decades old, concept, which is in past 2 years, it has gained very, very high focus. But still, I think that we need to do much more than what we tend to integrate. One of the major things is not to introduce certain things that I think should always form a part of One Health. And when I say that, I have been, and we had discussed with Dr. Meher also, I think last year or something, that there are more than 500 drugs which have antimicrobial effect. They have got suboptimal effect. So, and they are taken by even something which is very common like statins, paracetamols, and such like things. I mean, they have more than 500 such drugs have, and they are just thrown into the environment, creating more chaos. They have got some optimal effect upon gut microbes also. So we have to be very, very thoughtful about what we are using even for our own health, besides antimicrobials. So that's something which we need to, collectively come across and think. And as far as conditions are concerned, yes, India has a lot more challenges, which are with the world's largest population holding up in this part of the region, of the world, and more than 140 crore people. So that's something which is very difficult to handle everything at a fast pace. So things are changing, as you must have noticed in the government, being in the government committees, and something which I have also noticed in past decade, that things have moved fast. People are much more aware now. They do have respect for antimicrobials, and only thing is that yes, like what Dr. David Livermore was saying about the data that was produced. So we need to have much more integrity, I would say, or much more thoughtfulness while putting our data together. So it is not just publishing of resistance antibiogram or something on those aspects. It has to be why it is happening, as very rightly said by David Livermore, that we have to put that word why into it. And Mayor and all our colleagues, we have promised ourselves to have a look at and review such things. So at least in our own studies, to make it much more plausible and more rational. So thanks a lot for putting together all your thoughts, all your good work, and complexities of One Health, especially focusing on research. And I'm very intrigued by linking economies, the economic benefits. And that is what we have seen, that once you put across the economic benefits, All any hospital administrator would love it, in fact, of doing certain good things, especially on antimicrobial usage and such like things. Even nationally, obviously, the national leadership, they understand finances much more. So thanks a lot, Dr. Nino, once again, and thanks, Dr. Meher. Any questions, or you would like to take it later on?
May I ask a question? Yes, sir. May I ask sir, question?
Dr. Meher, would ma'am, just 1 minute. I think Dr.
Yes.
Meher says that there is a paucity of time here, so we'll let
Yes.
the other this thing go on. But we'll have your question, I think, at the end of the
Yes.
of this
Thank
webinar,
you.
towards
Yes.
the end, so that.
Yes.
But we definitely would have, ma'am. We'll come back to you on that. Thank you.
Raman, actually, I have to attend a departmental dinner. People are waiting for me. So if you can, I can answer questions. I have to leave now. I can answer the questions.
We are running short of time.
We're
I'm so
running short
sorry.
of time. That's what I can see
Later,
on Dr.
later.
Meher's face.
You can email me.
So yeah, that
Yes.
is better. That is better, and we can email the all the participants on the
Yes.
audience faculty here who's interacting. So we can email them also the
Thank you.
answers.
Thank you.
Thank you so much. Thank you.
Thank you so much, ma'am. Thank you so much, sir, for that wonderful session. Every action has an equal and opposite reaction, and we are as important as the microbe, I think. Ladies and gentlemen, the time has come to hear our illustrious guest, Professor Patrice Nordman. We have grown up listening to him, hearing him, and reading his immense quantum of work. We have Professor Chand Wattal, who will be moderating the event. Thank you so much, sir, for finding valuable time. And I welcome Dr. Farah Marzouk to please introduce herself and then welcome Professor Chand Wattal.
Thank you so much, Dr. Meher, for the kind invitation to this event. It's a great pleasure for me to present Professor Chand. But first, I need to introduce myself. My name is Farah Marzouk. I'm medically qualified doctor, assistant professor in the Department of Microbiology and Immunology in the College of Medicine and Health Sciences in the UAE University, located in Al Ain in the United Arab Emirates. So it's a great pleasure and honor to be attending this event and to present our eminent moderator, Professor Chand Wattal. He is the chairman of the Clinical Microbiology and Immunology in Sir Ganga Ram Hospital in New Delhi, India. Professor Chand obtained his medical degree from GMC Kashmir and his MD from PGIMR in Chandigarh. He is a postgraduate teacher since more than 35 years. He is a recipient of several prestigious awards, including the Dharma Vera Award for Excellence, a Snandi Award as the Best Publication of the Year, a Long Distinguished Service Award by Shri J.P. Nada, the Union Health Minister, and the Best Publication of the Year in Virology published in IGMM. He is also recipient of IMM Endowment Award in 2016, Agural Irish Award in 2023, R.A. Pujawa Award by IMM DC in 2023, and also he is the immediate past president of IMM in Delhi. He is editor-in-chief of IGMM. He's the chairman of the EQS program of India in clinical microbiology under the aegis of the national body of IMM of the country, and he has more than 35 years experience in the specialty, a lot of prestigious publications, almost 126 publications in prestigious national and international journals. His current citation index is 1,395 with each index of 31, and he has delivered and chaired more than 274 sessions and lectures in different prestigious events. Thank you so much, Prof. Chand, for being with us today. The floor is yours.
Thank you, Dr. Bara, for the kind words. I wish to thank Meher also to give me the opportunity to be here and listen to the stalwarts in our field. And the next speaker is Dr. Patrice Nordman. I don't think he needs any introduction to this gathering who are here in this afternoon and evening. But for the freshers or the PGs who are listening And I'm sure they must have gone through his huge number of publications on the AMR and the mechanisms of resistance and the new drugs. He's a professor and head, also founder, medical and molecular microbiology department, emerging antibiotic resistance research group, section of medicine, faculty of science and medicine, University of Fribourg, Switzerland. He's a head and again founder, Laboratory Strange Estli. I can't pronounce that in his language. So it is for the National Institute of Health and Medical Research in France, the National Reference Center for Emerging Antibiotic Resistance for Switzerland, Health Ministry and European Institute of Emerging Antibiotic Resistance, UNIFR Switzerland. He is the founder and head research unit in SERM 914, Emerging Resistance to Antibiotics, 2008 to 15, founder and director of the French National Reference Center for Antibiotic Resistance, gram-negative rods, carbapenemases, 2012 to 15. You will, I'm sure, listen from him more about these carbapenemases. He is a member, scientific and steering committee of the STAR program, Antibiotic Resistance Control, Ministry of Health, and BAG, OFF, FPS, Bern, Scientific Committee of ANRESIS Network, Epidemiology of Antibiotic Resistance for Switzerland, Ministry of Health and Bern. He has a cumulative citation of more than 1 lakh or 100,000. We talk of publications more than 880 around and H index of 162. In 2014, and European Society of Clinical Microbiology and Infectious Diseases gave him the Excellence Award in Clinical Microbiology and Infectious Diseases. And ASM in 2015 in the ICAC Research Award was given. ASM Premier Award honoring outstanding accomplishments in antimicrobial research, San Diego, CAUSA 2015. These are his main awards that he has received. He is also the vice president of various organizations. I welcome Professor Nordman for his presentation on insight into molecular mechanisms of resistance. Welcome, Professor Nordman.
So I thank you very much for your very nice word, you know. And now I'm going to try to share my slide. And here it is. Wait a minute, maybe it will come or not. Do you get it or not? Hello?
Not yet.
Not as yet.
No.
Not yet. And here? No, nothing.
Nothing.
Aha. It is written stop.
Here you have a copy.
Well,
No,
I
not
think
yet.
well,
Would you like
have a
to
copy.
mail me, sir? If you would like to mail me the copy, then I'll present from here.
I already sent you today.
I see. I'll just check.
Why it doesn't work? We don't know.
Otherwise, just sir,
I
stop the
stopped what-
sharing and reshare.
I stopped sharing. I don't know. That's so by the way, I thank you very much for your by waiting, you know, for the sharing. So a few words to thank you very much for inviting me to this meeting. I'm very pleased to see all my friends from Middle East and from India and from all over the world, but mostly Middle East, where I've been many times, and in India, where I've been so many times, and I remember how kind you were to welcome me to give a series of talks. So now it's just an online talk. Do you want I try again to share, or I'll let you do?
No, I've got it. I think.
You get it, sure.
Yes,
Super.
just
It's surprising, you know. We go on the moon, and sometimes, for unknown reason, it's difficult to share.
They have, once you finish some of the naughty things, as some political questions.
Yes, exactly.
Is this visible now?
Yes.
Super. For me, it's super.
Great.
So maybe I will, since
Please go ahead.
I cannot do anything, maybe I will tell you just next for the next slide.
Yes, yes, yes. Perfect, perfect. Go ahead, sir.
Okay, so next, please. So, you know, in terms of emerging antibiotic resistance, I'm going to talk about the problem that are emerging mostly in community-acquired pathogen and in hospital as well as in community-acquired pathogen. In terms of novel emerging antibiotic resistance, everything is focused on gram-negative. So for the next 20, 50 years, I'm talking to our younger colleague, the future will be there. For their career in gram-negative, and my guess would be mostly in E. coli, because it is, as mentioned before, this is a source of animal and human infection. So next, please. So the very well-known problem was the so-called ESBL. You know, this is this type of expanded spectrum beta-lactamase, which gene are located in plasmid, so very easy to be transferred from one antibacterial state to another. And most of these ESBL producer, in E. coli or in Klebsiella pneumoniae, for example, are co-resistant to a variety of non-beta-lactam antibiotic resistance. This means so there is not so many possibility for treating those bacterial infections. Next, please. And so the current situation of the worldwide distribution of those ESBL producers in E. coli is the following. You see on that slide, you know, this is from a very nice paper published in 2022 in The Lancet. You can see that the epicenter of the problem is Bangladesh, India, Pakistan. You can see that on that slide. And I remember, you know, the very first CTXM15, which is now the most common, you know, the most common antibiotic resistance determined as an ESBL. This one came from India because, you know, our group, you know, published the very first Klebsiella pneumoniae producing CTXM15. And now we are well aware that CTX3 and 15 are very common, you know, in this part of the world. But the beauty of this story is we are not covered all over the world by ESBL producer in E. coli reaching more than 50, 60, or 70%. Whereas in this region of the world, they have a huge percentage of E. coli producer of ESBL. Next, please. And so the consequence of that is, you know, if we travel in a given part of the world, and again, this part of the world, as well as, you know, North Africa, Middle East, and China, and Asia in general, there is more risk to get colonized and possibly infected than in other parts of the world. And I mean North America, South America, Europe, and Northern Asia, such as Russia, for example. Next, please. So my opinion is there is very low usage of many tests that are available for detecting ESBL production. And one of those tests we developed is the so-called rapid ESBL NP test that may detect ESBL producer from blood culture, from culture of bacteria, or from urinary tract infection. So we just have to take the sample, to centrifuge a little bit, and then to use cephalosporin, the cephalosporin cefotaxime, as a marker of presence of an ESBL. And if there is an ESBL, there is hydrolysis of this cefotaxime, and then modification of the pH of the medium becoming orange. So by decreasing the pH, the pH indicator change of color from red to orange. And in another tube, when we are doing the exact same experiment, but we add an inhibitor of ESBL, such as tazobactam, then we will get no hydrolysis. And if we compare the two tubes with or without inhibitor, we can deduce presence of an ESBL. And this test is now marketed, and it can be available worldwide. And my opinion is, by using this test, in particular from blood culture, where, you know, if you have a positive blood culture, we have up to 10 to 8, 10 to 9 CFU per ml, then in those cases, we can use very well this rapid ESBL. And in terms of better usage of antibiotic, meaning antibiotic stewardship, this is on my eyes, you know, a very good way to choose a carbapenem or not to choose a carbapenem for treating an ESBL infection. Next, please. Second most important problem, which is now evidenced among community-acquired pathogen, is the problem of carbapenemases. And there is a large variety, NDM, KPC, oxafortuase, as we know. Next, please. And so the very first in terms of occurrence in the world were the so-called KPC identified in Klebsiella pneumoniae. And you can see that those bacteria are totally resistant to all beta-lactam, and co-resistance is very frequently observed. And in most of the cases, those bacteria remain just susceptible to fosfomycin and colistin, which are not a very important antibiotic in terms of efficacy of treatment. Next, please. And so this was, I would say, 15 years ago. Now, the current situation is still, you know, there is a lot of this KPC producer in the US, in South Africa, in eastern part and southern part of Europe, such as Italy, Greece, Poland, Hungary, Romania. There is a lot of KPC producer, and in India, Pakistan, and Bangladesh, again, there is a lot of KPC producers. But by chance, those KPC mostly remain located in Klebsiella pneumoniae. So this is not a very common, you know, common source of carbapenemas among community-acquired pathogens. Next, please. This is not the case because for the NDM, you know, the NDM stands for New Delhi metallobeta-lactamase, because the very first isolate was a Klebsiella pneumoniae identified in Sweden from a patient, Indian patient hospitalized or coming from New Delhi. And again, you have the same type of multi-drug resistance pattern. Next, please. One of the main problems is, as opposed to the KPC producer, worldwide, what we are seeing is a lot of community-acquired pathogens that are prone to possess an NDM, and in particular NDM5. And recent papers show a rapid spread of a given so-called ST type of E. coli that produce NDM5. And one of the problems is those bugs in the community may become underestimated. We may not always identify those NDM in the community, whereas in the hospital, usually people identify very well those type of carbapenemas producers. And then this E. coli may enter in the hospital and may be the source of hospital-acquired infection. Exactly the same we have observed, I would say, now 25 years ago, with the problem of CTXM. At the very beginning, CTXM were located only in E. coli. And then thereafter, the plasmid were identifying Klebsiella pneumoniae, and those ESBL producers were identifying the source of hospital-acquired infection. And I believe what we are going to see, and what we are seeing, in fact, right now, is the silent spread of E. coli, which be the source of hospital-acquired infection related to NDM5. Next, please. Yep. And so one of the problem is the fact that in some region of the world, and again, in India, Pakistan, Bangladesh, it is estimated, depending of the study, but it is estimated the resistance of E. coli to carbapenem may reach 20% or 16, 17%, which is very high as compared to the resistance rates we observe, for example, in Europe, which is around 0.1% at the maximum. In Switzerland, the rate of resistance to E. coli to carbapenem is 0.00%. Next, please. And the third type of carbapenems that we may observe among community-acquired pathogens is this OXA48, which are often associated with an ESBL. This means that in terms of antibiotic susceptibility or resistance, more or less this is the same as NDM producer or KPC producer. And I remember 20 years ago, we identified the very first strain, which was a Klebsiella pneumoniae from a patient hospitalized in Istanbul, in Turkey. And then we performed several studies identifying this OXA48 in the Middle East, in North Africa, and then in Europe. Next, please. And so in 2024, today, we estimate that OXA48 remain located North Africa, where there is a huge reservoir, so from Morocco to Egypt, and then in Turkey, in Iran, very likely, in Europe, due to exchange of population between North Africa, Middle East, and Europe, and again in India and Pakistan, Bangladesh, and there is a mix of derivative of OXA48, and the very common is OXA181. And you see from that slide, there is at the end very few, there is, but very few in the US and very few in Canada, and not so many in South America. There is, but there are, but not so many as compared to, for example, in Europe, where clearly OXA48 producers are becoming the most important group of carbapenems. And for example, in my reference center here in Switzerland, by far, OXA48 are the leader in Enterobacteriaceae among carbapenems. Next, please. And one of the reasons, in particular for OXA48, one of the reasons of the spread is the fact that this OXA48 gene is located on a very specific plasmid. Worldwide, a few exceptions as always in medicine, but worldwide, this gene is located on a 62 kb plasmid, always the same worldwide, and this plasmid transfer at a very high frequency, 100-fold higher than the regular plasmid, from E. coli to Klebsiella to Cloacritum Proteus mirabilis. Why we have detailed the genetics behind that is because this gene is located on a transposon, that means a mobile element, which is inserted in the regulator factor that limits the spread of the plasmid. So this insertion leads to derepression of the transfer of this OXA48 gene. And this explains that on a daily basis, a patient may harbor E. coli and Klebsiella pneumoniae with the exact same OXA48 determinant. And second, in the hospital, we may observe easily outbreak related to this OXA48 to a variety to antibacterial species. Next, please. And I remember when I was working in Paris, I asked my secretary, my assistant, who went on vacation in Morocco, to take samples from the ground. And I said, rather than to go swimming and I fun only on Morocco, please help us. And she took some samples from different places in Morocco. And from that, we identify Serratia that produce OXA48 determined. And from that very pioneer, very first study, we were able to say this OXA48 is clearly in the environment at a very high level. Next, please. And what we are seeing today in many parts of the world is a variety of OXA48. And some of them, such as OXA244, which is spreading in E. coli and spreading in community-acquired pathogen, may confer very low level, if any, to carbapenem. And so you can see just, I have put, a yellow square around the imipenem, ertapenem, and meropenem susceptibility. You can see that that bug remains susceptible to carbapenem, or just a vague decrease of susceptibility to carbapenem. This means that it is very difficult to detect. And by making the genetic analysis, we were able to identify that this gene is located sometime on plasmid, but sometimes on the chromosome. And then the expression is at a very low level, only one copy per strain. Next, please. And so again, my belief is those days we are not using enough rapid diagnostic testing. So, for carbapenemol, rapid diagnostic testing may be based mostly on biochemistry, such as the rapid carba-NP test, which is shown here, immunology that works quite well, and PCR-based technique. The problem of those PCR-based techniques, they remain more costly than biochemistry or immunology. So biochemistry is the test we developed 50 years ago, and so it is the same idea as the ESBL. So we take carbapenem, we extract the soup of protein from a bacterial culture, from blood culture, or from urinary tract infection, and then if there is a bacteria that produces carbapenemase, we have hydrolysis of the carbapenem and modification of the pH of the solution. And so the pH indicator turns from red to yellow. That's a very simple test that mostly works quite well. Then next, please. Just a word about another emerging problem, which is often associated with carbapenemase. And we have seen that in many community-acquired pathogens. And this is the so-called 16S RNA methylase. So this is methylases that modify the target of aminoglycoside, that is 16S RNA. Next, please. And so this has been reported by the group of Patrice Courvalin 20 years ago, just before he retired. And it may confer, this resistance to amikacin, netilmicin, tobra, janta, kanamycin, mostly all the aminoglycoside. And it is often associated to various degree of resistance to beta-lactamase, and at minimum ESBL, and often carbapenemase. Next, please. And we have performed a study here with the carbapenemase producer we are receiving on a daily basis in our reference center here in Switzerland. And what we can see is clearly a trend for increasing number of methylase producer. Next, please. And here, a lot of paper reporting more or less the same. Next, please. And so, what about the novel molecule and the resistance to those novel molecules? So, those molecules such as ceftavibactam, meropenem vapor, imipenem rolobactam, astronam avibactam, and cefiderocol are used mostly in for treating hospital-based infection. But depending on the countries, sometimes there is a possibility for treating either really community-acquired infection or hospital-acquired infection, but the patient has to be treated as a community patient. So next, please. And so what we are observing worldwide is for ceftavibactam, in particular with KPC, a large number of variants that confer resistance to ceftavibactam. One nice thing is, you can see that on the last slide, those variants from KPC2 or KPC3 are becoming more susceptible to carbapenem. So they recover, in a way, some kind of susceptibility to imipenem. And you can see on that slide, if you look at the circle around the imipenem, which is on the second line for KPC3, yes, very good. And then when we go for KPC41, you can see the diameter around imipenem, which is much higher, at a point that this strain remain susceptible to imipenem. And so if you follow many guidelines in the world, and I'm thinking just about the UCAS, European guideline, or the American guideline, whatever the carbapenemase is, they consider what is important is susceptibility or resistance to a carbapenem. But for the KPC producer, we may consider clearly using carbapenem for treating those patients, because if you look, they are totally susceptible to imipenem. So this is in a way a balance in between acquisition of ceftavibactam resistance and recovering of susceptibility to imipenem. And this is observed to many variants related to resistance to Casavi, many KPC2 or KPC3 variants. For OXA48, we don't have a lot of ceftavibactam resistant mutants. So this is good news in a way, because for antibiotic resistance, I think it's important to underline the good news. There is bad news, but there is some kind of good news, and this is for me a nice news. Next, please. One of bad news is when you have resistance to ceftavibactam, we have clearly resistance to cefiderocol. Just why? Because cefiderocol is a derivative of ceftazidime. So it is logical that for a series of these KPC variants that are resistant to ceftavibactam, they become resistant to cefiderocol. Next, please. And about these KPC variants, this slide is to underline the diversity of KPC. That makes a lot of publication, but at the end, which is interesting is the overall ID, and the overall ID is there is a spread everywhere of these KPC variants that are resistant to ceftavibactam. Meaning, we have always to test susceptibility to ceftavibactam to be sure that it works or not. Next, please. For cefiderocol. Alors, cefiderocol has been launched, has been considered as the best antibiotic for treating multi-drug resistant gram-negative bacteria. But there is a lot of paper, and some of our group are represented here, showing that cefiderocol resistance may be acquired quite easy. And so it is observed in Pseudomonas, in Acinetobacter, in Maltophilia, in Enterobacteriaceae such as E. coli. And even we were able to show that in Acinetobacter baumannii, this is bacterial species which is naturally highly resistant to many antibiotics. And so if those Acinetobacter baumannii produce the SBL pair or the carbapenemase NDM, they become resistant to cefiderocol. Next, please. And among the very recent approved antibiotics, and I'm thinking about Astrana avibactam, that has been approved in Europe, and it is on the market in several European countries. I don't know the current situation in the Middle East or in India, Pakistan, Bangladesh, or in North Africa. But in Europe, a series of countries have already this antibiotic. If we look to the literature, there is a few of NDM producer strains that co-produce a cephalosporinase of the CMY type, and that they may have within their penicillin binding protein a modification, insertion, that confer resistance to Astrana. So this combined mechanism is a source of resistance to Astrana avibactam. Even so, this antibiotic is not so frequently used worldwide because the approval still remain very much limited. And with colleagues from Paris and from people from Pakistan, we were able to identify that those strains are identical in Paris. Some of those may be identical in Pakistan, Switzerland, and Paris. So my understanding of that is those strains very likely have been scattered, in Asia, and then they go with the patient from there to Europe. Next, please. And so my last slide is the following, and I think it's important on 2 or 3 aspects. My idea of that slide is like, the story of Saint-Exupéry, The Little Prince. And in The Little Prince, he was saying what is important is sometimes what you are not seeing, what you feel. And what you are not seeing is, unfortunately, the gut flora. And the spread of the gut flora without identification of antibiotic resistance may be the source of the problem in terms of spread of multi-drug resistance bacteria worldwide. And this is just the opposite of the COVID. Because of the COVID, let's say we have, my estimation will be wrong, but let's say we have 10 or 20 carriers for 2 infected. But the infected, we identify very clearly around us, in the community, and so we can very easily say, okay, we are seeing a novel outbreak, we close different facilities, we ask the people to stay at home, and what we are seeing today is sure there is some COVID infection, but they are not so common as 3 or 4 years ago, because this virus was able to make clinical syndrome to a diversity of people, in between the young people, the old, the women, the men. And so we were able to identify the problem. For emerging antibiotic resistance, we can identify the problem in fact, and I'm thinking about my position here in Switzerland, only by screening hospitalized patients coming from abroad, because, you know, the problem of emerging antibiotic resistance is very few, you know, in Switzerland. So it's very peculiar situations. So today in Europe, for example, there is not identification of antibiotic resistance, and this is the same, you know, in many parts of the world, such as, for example, Middle East or India, Pakistan, and Bangladesh, or China. So non-identification of silent spread of antibiotic resistance is going to be the problem. So I am sorry to end my talk on a not so optimistic point of view, but I don't see very well how we can reverse this trend. What I cannot foresee is the speed of the spread. This I cannot say, but for sure, 20 years from now, in gram-negative, in particular in Enterobacteriaceae, I see a silent and sure spread of those multi-drug resistant bacteria worldwide. I thank you very much for your attention.
Thank you. Hello.
Thank you so much.
Yeah. Thank you, Professor Nordman. It was a wonderful feast of knowledge, and I'm sure my all colleagues and listeners will be delighted to have heard you. And obviously, we have shared a lot of your literature in India. As I told you while we were waiting for your slides, that we did have the lot of information from Dr. Walsh, Timothy Walsh, and articles when we talked of NDM. And when one of the global conference was going on here on antibiotics in 2012, we had a small poster and it was taken a notice of. And then we were, next day it was in the newspaper, superbug at my hospital. So I had tough time with the trustees to explain, and I almost lost my job. So I have a small relationship with both of you when you talked of NDMs. Small kind of information to share with you while we are talking of the kind of systems that we have in India. We are not faced with KPC as on today. I'm sure my Indian colleagues will try and collaborate and say that we are primarily inundated with NDMs. And our main problem is NDM. And obviously, E. coli with PPP3 is catching up, and we are having that ST strain over in India. So that is our primary concern as on today. And main organisms plaguing us in gram-negs is the Klebsiella pneumoniae and Acinetobacter baumannii. These are the two bugs that are killing our patients in the ICUs and are also a major chunk of HAIs. We do have E. coli, but we do find them more amenable to treatment, including Pseudomonas aeruginosa, which we do find that they are amenable to treatment. But worse are the Klebsiella pneumoniae and Acinetobacter baumannii. And to add to the insult is the fungal infections like Candida auris and Candida tropicalis. These are the kind of things that are plaguing us. But anyway, we had a wonderful time hearing you. I think we are having shortage of time. And if you have any questions or at the end of it. So any comments from Professor Nordman? Yes, Meher, you can take over from here.
Thank you so much, Professor Nordman and Professor Chandwatar. That was an amazing session, fluidly delivered. We had a fantastic time listening to all that. We'd love to have more time to discuss with you, but unfortunately, because of paucity of time. Oops, sorry, what is this? I'm sorry about that. I need to just go back to.
Don't hesitate to share my slide. You know, if some people may be interested to have a look.
Thank you. Absolutely. And I'm sure there are many questions coming up, and we would love to talk to you more, but we just need to move forward. Thank you.
Thank you.
Thank you. Ladies and gentlemen, we're ready for the last distinguished speaker, Dr. Manish Paul, who will be talking about challenges in developing effective antimicrobials against XDR and PDR gram-negative bacilli. And to welcome him, we have distinguished moderator, Dr. Abdul Ghafoor. And to welcome him, we have another dashing PI from Team Dash, Dr. Rajni. Dr. Rajni, will you please introduce yourself and then do the honors?
Yes, ma'am. A very good evening to everyone. I'm Dr. Ekadashi Rajni. I'm a graduate from Lady Harding Medical College and a postgraduate from Maulana Azad Medical College, where I had the very good fortune of meeting Meher ma'am. She was my senior in Maulana Azad Medical College. And currently, I'm Professor Microbiology in Mahatma Gandhi Medical College, Jaipur, Rajasthan. So it's my proud privilege to introduce Dr. Abdul Ghafoor. And he is a senior consultant and adjunct professor in infectious diseases at the Apollo Hospitals, Chennai, India. Among several other achievements, Dr. Ghafoor is the primary author and coordinator of the Chennai Declaration. This is a renowned Indian document and initiative to tackle the challenge of antimicrobial resistance. He is a former technical advisory committee member for the National Antibiotic Policy, Ministry of Health, extremely active in academic, policy, research, socio-economic, and political aspects of infectious diseases. He is the managing partner and lead strategist at Quorum Veda Consulting Services. Again, then he is an advisory and jury member of the Longitude Prize, delivered several lectures, and has a series of prestigious international publications in journals like BMG, Lancet, etc. He is on the editorial board for several international journals and received the Indian Medical Association Oration Award for his contribution towards tackling antimicrobial resistance efforts. With this, I'm very happy to welcome Dr. Ghafoor on this online platform to moderate the next session. Please, Dr. Abdul Ghafoor.
Thank you, Dr. Rajni.
Yeah.
Our next star speaker is Dr. Manish Paul. And I'm not going to read out his TV slide because if I do that, I will be diluting his most important achievement. That is, he is the lead co-inventor of the first Indian anti-infective to the world, that is cefepime and metazobactam. Dr. Manish, I'm an infectious disease physician working in a cancer center. Every day, I treat patients where only 1 or 2 antibiotics are effective or no antibiotics are effective. And when I'm holding their hand, I feel helpless. And for myself and for my patients, any scientist who develop, invent, and deploy new antibiotics is an angel and a godsend. So to me and my patients, Dr. Manish, you are an angel and godsend. Over to you. We are so enthusiastic to listen to your story. Thank you, Manish. Over to you.
Thank you, Dr. Ghafoor. Thank you, Dr. Meher, for the opportunity. Hey, I would like to have the privilege to share the presentation. I have it now. Thank you. And also, it is so wonderful to listen to Dr. Meher, who put up the complete background, so it saves a lot of time for us to repeat those things, and also endorsed by Dr. Neelam Taneja. She did give about brilliant data. One thing I would like to slightly say differently is, we always say India is the hub for AMR, but I don't think that's so true, because AMR is a global challenge. We have AMR all over the world. And Indian data, though we collect, such a massive country, right? It wouldn't definitely not represent the AMR of the entire nation per se, but only the collected data, of course. And of course, thanks to Dr. Livermore, and he has been one of our mentors during the invention of N-metazobactam, in addition to many other scientists. And yes, thanks, Dr. Sardana, for moderating that quite well and concluding it in a very precise manner. And it's beautiful to listen to Dr. Nordman. The importance of diagnostics is so critical. Coming to my topic, challenges in XD, extremely drug-resistant gram-negative bacterial anti-infectives. This is an area where I think all of us struggle a lot. Minimize this, okay. Without going too much detail into these facts, which everybody is aware of it, I would like to highlight the blue line here. AMR is complex and no individual nation can address this major public health problem alone. And it fits quite well with the topic of today's presentation and the whole symposia itself, that it is one health approach we have to take. Because anytime we say we are not looking at only one sector, or when we look at holistically but not practically translate that, it just becomes a moot point. And of course, coming to the major area of multiple drug resistant bacterial infections, now even the last resort antibiotics, right, like Dr. Nordman showed the data, it is really scary to see the way KPCs have also evolved. I say KPC 156 or 163, I think, and that's scary. We are going on identifying newer KPCs and newer carbapenemase producing bacteria. And when bacteria become so multiple drug resistant, the challenge comes is with the discovery of novel antibiotics. Because every time, as we know from the history of anti-infectives itself, when the first antibiotic, penicillin, came into existence, before it was approved, we had MRSAs in the circulation, which means to say that we have already wisdom of AMR among the microbes much long before we could even ever think of identifying or discovering and inventing any new molecule. So the way I say it is, every time we say, hooray, we got a new antibiotic, microbes would say, okay, we know about it. It's no big deal that you invented a new molecule because we know all about it. So we have every arsenal with us how to combat it. So this is where how our collective human intelligence, collective I say because it is not one person's activity, even inventing this molecule in metasobactam, though I was the lead biologist there, it is not one man's activity. It is a collective activity of so many people in the company who worked quite hard. We had in vitro scientists, we had in vivo scientists, pharmacologists. It's a whole journey. I will talk about it a little while. Now, what we have to do is we have to re-engineer the approaches of existing antibiotics. Inventing newer molecules is very good, but we already have exposed the bacteria to a certain set of antibiotics. Can we re-engineer them? Can we bring something supporting these antibiotics? So that's when we have to figure out how antibiotic against drug-resistant bacteria can be increased through structural modifications, right? And that's where we identified enmetazobactam as well. So further to that, we have to understand the regulatory and translational challenges for antibiotic resistance. Because now when you're re-engineering any molecule, because bacteria know this, any modifications around it, then for a microbe to become resistant to that is quite easy. Oh, here is where we have to look at a different approach. And what is that approach would be? I prefer to look at the virulence factors of the microbes rather than going at the microbes directly. Because anything we go directly at the microbes, they would again reinvent themselves and reactivate themselves multiple ways. So instead of triggering that activity, if I can attack its virulence factors, one of them being the beta-lactamases, right? And that is the approach. What I'm mentioning here is enmetazobactam, where we have approached attacking its enzymes rather than the bacteria itself. So here, in a way, bacteria doesn't know exactly, oh, there is a new BLI there. It is just confused now. Well, we have, again, cefepime attacking us. What's going on? So they may be thinking that humans have surpassed them. But before they catch up, I think we can take care of the carbapenems. Because when we start using carbapenems as the first line of therapy, we are, in fact, pushing the microbes to the corner to bounce back at us. So to prevent that, we need newer BLIs, which would come. Of course, we have quite a few have come up, and I would appreciate even the Zainich, which is the Zidibactam from Wokhard. That's from India again, the second molecule, which from India, which has made it to the market now. Of course, that is the one which is now, it is not exactly a complete BLI. It has also inherent antibacterial activity, but it does supplement the antibiotics, whichever it can be attached with, so that carbapenem resistant microbes can also be treated with that without introducing high pressure by the carbapenems themselves. So going to the One Health side, we have heard quite a bit of it on One Health, what it is and why we have to collaborate between all the three verticals. Because if we do not work in tandem, I think we are going to lose the battle again. The food industry. Of course, Dr. Taneja said we shouldn't blame the food industry or the agriculture or animal sectors, but I think it is not to blame anyone. Each of us have to own up the responsibilities in our own verticals and come collectively. And as she mentioned, there is no coordination at the policy level of all the three verticals to come together and address this challenge. So that is something as a policy matter we have to address. Because when we do that, we are going to take up and address the 5 sustainable developmental goals, which are critical as part of the 7 SDGs for the world to become more sustainable. We can address poverty issues, health and well-being, inequalities, hunger issues, and also the loss of manpower, which could happen due to highly drug-resistant infectious diseases. Now, we always think, where exactly is the infection coming from? Though this is a little older paper, maybe about a decade old, but still it is quite relevant to us to look at how anti-infective resistances or antimicrobial resistance comes from multiple sectors. And when I see this, the right side circles, the animal and humans are quite equivalent. And they are the ones which are contributing to the high resistances. So food animals are one more area where we have to pay attention to. Now, when this connection happens between all the three, we can definitely look at how to address AMR. And I'm not going to go into details of this, but in addition to all those things that were mentioned, I would bring in one aspect. I'll skip this slide as well. Access to antibiotics. This is very important aspect of controlling AMR. This was not touched, so I deleted other slides. The next 2 slides, I'm going to talk about why it is important to look at access to antibiotics as well. If there is no access to the right kind of antibiotics in the clinical setup, the clinician is helpless. When a patient walks in, they have to deal with it. So what do? So improve access. GARDP, the Global Antibiotic R&D Partnership, an initiative from WHO, I think that is doing an amazing job. And cefiderocol is one of the molecules that is going to come into the market very soon, I believe. And they are looking at multiple programs to ensure that these antibiotics, which are not known to add additional antibiotic resistance mechanisms, can be brought into the market so that the LMICs, which is a major challenge, where the major challenge is access to antibiotics, can be addressed. And the next important thing is the quality of antibiotics. We have a lot of substandard and falsified antibiotics available in the market, nearly 40% of them. This is what the WHO report says. And this is yet another reason why we have a major challenge in addressing multi-drug resistant organisms. Because when substandard means when it has got lesser potency than the available potency, approved potency, or we all journey so many years to bring a molecule to the market, and then if the set dose, the therapeutic dose, is not maintained in the formulation available over the counter or when it is administered to the patient, microbes are going to develop resistance again. So quality of the antibiotics is something very, very, very important aspect we have to pay attention to. Now, what are the major challenges? One of the things is the vulnerability of antibacterial drug R&D, because whenever we talk about antibiotic resistances or drug development, the major thing people say is, oh, there is not many molecules, not many avenues. That's not true. We have done so many research. I think, Dr. Ghafoor has started a group called Entrepreneurship Group, Innovation Entrepreneurship Group, wherein he's trying to bring in clinicians to be part of becoming innovators or entrepreneurs themselves. That is a very good initiative to engage them to understand the problem, because they know the reality in the clinics. And if they can partner or themselves come up with either diagnostics or finding newer ways of treating the infectious diseases, I think I'm looking specifically for infectious diseases, though that is broad. His forum is broad one, but infectious diseases, I think that is going to address quite a lot of problems. So some of the highlights I mentioned is the critical medical needs will be addressed by, understood by them, but the initiatives, right? Push and pull initiatives have been done by the global agencies, but it is not yet fully implemented. Only thing I can look at is the CARBEX, the BARDA, those things have come into play. But the initiatives where once the product comes to the market, how could we push it to reach the clinicians? Because drug discovery journey of anti-infectives is a very, very, very arduous journey with low return on investment. That is the reason there are very few companies who are actively working on it. And that's when push and pull incentives become highly, highly important. And then we have to look at also non-traditional approaches. I will touch a slide upon that later. Now, here what we have to do is we have to look at the impact on bacterial growth and also virulence indirectly, as I mentioned earlier, because when we look at these indirect methods, I think we can address them as well. This is, we are conditioned to think that I have to hit the molecule directly, only then I can kill the microbe. No, there are multiple ways, just like the BLIs. When you look at the recent studies, and phase 3, predominantly most of them are BLIs. Out of 28 small molecules in clinical trials, 21, I mean, most of them are BLIs, right? So, which is a good approach in my opinion, but of course we need newer molecules as well there. Now, what are the things we look at? The efficacy, the safety, right? These two elements are very important because many of the molecules which are in vitro active do not translate into in vivo efficacy. So that is where again the iteration and the loss of molecules is significantly higher. Then I just put the slide here. I'm not going to read everything and mention everything. Probably people would see it later. And I know it has been streamed online. People can always go back to watch the video to look at these slides again. The other point which was mentioned by Dr. Meher as well is about the impact it has on the microbiota. Right? How our gut microbiota forms the major, our human microbiota forms a major part of our human body's population of microbes. And we are specifically when we target the bacteria which are infecting, we may be affecting even other healthy bacteria. That is something we have to pay attention to. Now, we have to balance between refinement and innovation. I say this because when you're inventing Me Too drugs, when they come into play, they become resistant quite faster. That's when you're doing Me Too, go after BLIs, not after the novel molecules. That is one mantra, right? So the degree of innovation of new antibiotics definitely varies significantly because we have to look at same target, different structure. That is when we don't have to discover newer targets so much. Of course, we do need them, but existing to make it faster when the pipeline is so depleted, go to the same target, but come up with a different structure which the bacteria cannot easily destroy. Then look at different binding sites. The same, that is called repurposing. We have to repurpose many things. For example, we have the oxazolidinones, right? Which is a MAO inhibitor now, which is coming to antibacterial use. Similarly, look at the same molecule. If you identify newer targets, see whether it can bind to that site. Then we look at same pathway and different target and a newer target with the new pathways. These are these several ways how we can look at innovation of novel antimicrobials. This is a fundamental slide. All of us know about it. But this is where I want to tell you the arduous journey. When you identify the disease, coming to a target, it takes a long journey. Then we have hits identified by designed and developed by the medicinal chemist, which we have to find activity. The in vitro biologists work very hard to find that hit molecule. We had great number of team members in ORCID. We had in my team, the one Mr. Shakti Singh, Solanki, we had Bharani, who were quite a hardworking people. They worked quite hard to identify novel molecules. Then it went to in vivo, where we had Hariharan, who is now with Wokhart, and he's done amazing work in discovering and developing N-metazobactam. Then we come to clinical candidates, then drug candidates, and then comes the regulatory. These are the higher challenges. And when developing an anti-infective molecule, this is the journey I was talking about. Look at every stage, the failure rate is very, very high. The medicinal chemist makes the molecule. Look at the date, stage 1 is 2006. And when we finished out-licensing, it was 2013. And it came to market only in 2024. So that is the length of the journey. And we have to look at its MIC at the in vitro level, look at the broader set of organisms, look at the multi-drug resistant organisms, then bring in the efficacy activity, look at the tissue availability at the organ-specific regions by using pharmacodynamic models such as thigh infection model, lung infection model. Then we come to look at multiple strains, how many strains are available within India, and look at those strains. That's what we did. Then we go for safety. Finally, we come to validation of a candidate. This is the journey of inventing a new molecule. And once we did that, we look, and this triangle is very important to identify our therapeutic window, because we have to balance between toxicity and efficacy and to make sure we hit the molecule at the same time, do not cause any toxicity. And PKPD drivers. Normally, when you look at, we look at pharmacodynamics of the host and the host and the drug. But in anti-infectives, I always put the third eye and say it is a microbial dynamics, because microbes can break the molecules as well and also alter the host as well to a large extent. So looking at microbial angle is very important when you're discovering antibiotic. I'm almost at the end of my slides. So this molecule was invented by Orchid Pharma, right? And up to phase 1 ready, and we out-licensed it to Allegra Therapeutics. And right now I'm driving the phase 4 clinical trials for this in India. And in parallel, the drug has been launched in India on October 1st. So I'm proud to say that I thank my entire team who worked with me across the spectrum, not to mention any names. Across the spectrum, people have worked very rigorously to bring this molecule to the world. And Allegra Therapeutics has done an amazing job in clinical trials and getting approvals from the FDA, the EMA, and the UK MHRA. And India has worked very well as Orchid Pharma to get our approval for the Indian regulator. These are a few of the alternatives. I just keep the slide there and I move to the next one, which are conclusion slides, right? I would go to this slide mainly for the want of time. We have to, the last one, we have to work together to end this AMR crisis. Policymakers, drug discovery companies, clinicians, and above all, I would say the citizens of the world should come together, because AMR can be addressed only by engaging every person on this earth. If we become responsible in the way we use the antibiotics, I think we have solved 99% of the problem. We don't have to worry much. And that is where I would encourage, stewardship as a major contributor and contributor in addressing AMR rather than only drug discovery and putting the onus on the clinicians or the pharmacists. Regulations have to come in, but if citizens become responsible, I think we have solved half the problem. Thank you very much. Over to you, Dr. Ghafoor.
Thank you, Dr.
San Francisco,
Manish.
it's early morning here.
Thank you, Manish, for the wonderful discussion and the discussion on the challenges on drug development and the importance of saving whatever antibiotics left and the new antibiotics entering the market.
Thank you, Dr. Manish, for that excellent presentation. Dr. Ghafoor, are you going to add something more there, or we continue?
Oh, Manish, have discuss everything in detail.
Right. Thank you, Dr. Manish. I know the path is so thorny and so difficult, but I didn't know that it started in 2006. And finally, you see the light of the day in 2024. Many, many congratulations on that excellent work done. And I do agree that the bugs are smarter than us, and we need to be very mindful about how we use it. And we need the community to be on board. And the technical people need to come out to the community and work from down up. Thank you for that fantastic presentation and for the wonderful work done. Ladies and gentlemen, we are almost at the end of our fantastic symposium. I welcome Dr. Zaima Al-Jabri, our vibrant HOD, Department of Microbiology and Immunology. She's doing a great job of mapping the resistance in Oman, and we would love to map the resistance amongst our DASH group as well. We're looking for funds. I hope we find success. Dr. Zaima, please, the floor is yours.
Thank you very much, Dr. Meher. Thank you for this effort. And I would like to say a few words as we conclude this impactful international symposium on the antimicrobial stewardship and One Health. I would like to express our deepest gratitude to all those who made this event a success. Special thanks to Dr. Meher for all the great efforts. Thank you so much, Dr. Meher. And first, I would like also to extend thanks to our chief guest, Professor Rashid Al-Abri, the Dean of the College of Medicine and Health Sciences at Sultan Qaboos University. His support and presence also today has enriched this gathering and underscored the significance of this critical cause. And we are also privileged to have heard from the distinguished figures with their, insights have illuminated the path forward. We thank our patron, Dr. David Livermore, for his invaluable contribution and perspective in this work, which he has been doing. And also he has given us a very challenging task forward this evening for the work that we have been doing with the different centers so far. This symposium has also featured enlightening talks from esteemed experts in the field, Professor Neelam Taneja, and her talk on gains, challenges, and the way forward on tackling AMR and through a One Health platform. That talk actually offered excellent roadmap for addressing global crisis and many challenges that we face in the world today and the actions to be prioritized. Also Professor Patrice Nordman's insight into the molecular mechanisms of resistance and the new antimicrobials. This has also broadened our understanding of the ongoing scientific advancements. Dr. Manish Paul's discussion also for the challenges in developing effective antimicrobials against drug resistance in gram-negative bacilli. This has emphasized urgency and also complexity that is required, expertise involved in fighting these formidable pathogens. And I'm so grateful for our skilled moderators, Professor Raman Sardana, Professor Chand Watal, and Dr. Abdel Ghafour, and our dedicated DASH task force members, Dr. Ikadashi Rajini, Dr. Farah Al-Marzouk, Professor Ujula, Dr. Victorian, those moderators, and also the task force members have thoughtful questions and insights, have added depth and engagement to these sessions. And also they spark the dynamics that will keep surely influence our ongoing efforts. And above all, I would like to thank each of you, our dedicated participants, for attending, and also please feel free to share your insights and engage in these vital conversations with any of our speakers. We are sorry that we did not have the chance to address these questions because of the time, but your commitments to antimicrobial stewardship and One Health is the driving force behind the progress we aim to achieve. And as we part, so let us carry forward this work and the knowledge sharing that we shared also today, and challenges we acknowledged, and the resolve to continue the fight against antimicrobial resistance on a united global front. Thank you once again, and we look forward to continued collaboration and progress. And I wish to see you hopefully at our next gathering. Dr. Meher?
Thank you, Dr. Zaima. You're amazing. I love the way you round up the entire event. It's really the icing on the cake. Thank you so much, Dr. Raman, Dr. Chand Wattal, our big giants in microbiology. Would love to just hear in brief and we conclude. Thank you, everyone. Thank you, everyone, for
Thank you.
exposition.
Thank you.
Bye-bye.
Thank you
Yes.
from Hospital Victim Society India. It's excellent to be partners with all the great organizations. Thank you, Dr. Mayer. It's always something which we look forward to. And thank you, Dr. Zaima. I mean, that was wonderfully wrapped up. Very wonderfully wrapped up. Good choice of words.
Thank you.
Good one. Thank you. Thank you so much, everyone. Thank you.
Thank you.
Thank you.
Bye-bye.
Yes.
Dr. Udila Bochal, your question remains. So if you can just post it to us, we will let Dr. Neelan Taneja respond on it, or somebody else will respond on the.
I think we are meeting shortly.
Yeah, we'll be meeting shortly.
Yeah.
Professor Chand
She
Wattal,
may
please.
talk to us.
Yes,
Okay.
yes.
Thank you.
Wonderful speakers, obviously, and their disposition was as expected. And though Abdul Ghafoor has logged off, I would call him the David Livermore of India. He would also speak in the mic like him. So that was.
And I would just like to thank Dr. Sorry for interrupting, but I would like to congratulate Manish for highlighting that it is not we always blame India, but it is not an Indian problem. It is a global problem.
Very rightly said.
Yes.
Bass backing actually brought that out very well. They said you just create the conditions and it is there everywhere.
Everywhere.
Yeah. KPCs came about in US and
Our problem is
in
not.
Japan.
We
And
can
in
just
Japan.
say our bugs are smarter than the other worlds. We are the smartest.
Our bugs are not. Our bugs are not KPC.
Don't mess with the environment. I mean, that's what